Hello everyone and welcome to today's webinar organized by The Ophthalmologist and Bionx. I'm Alexandra Jones, I'm the editor of The Ophthalmologist, and I'm delighted to be moderating today's event, Creating a New Standard in Ophthalmic Surgery Visualization. I'm joined today by three fantastic speakers. Ron Schneider, CEO and co-founder of Bionx, Anat Loewenstein, Head of Ophthalmology at the Tel Aviv Medical Center, and Robert Weinstock, Director of Cataract and Refractive Surgery at the Eye Institute of West Florida. Our speakers will be discussing the Beyeonics One visualization platform, a technology that offers an exceptional immersive image of the surgical field, integrated access to information, state-of-the-art guidance overlays, and unprecedented comfort. Loewenstein and Weinstock will be on hand to answer any questions you might have throughout the webinar by chat. You can submit questions at any time by simply clicking the Ask a Question button. You will also see some polling questions pop up on your screens later on. If you have pop-ups blocked, you might want to unblock them for the time being so that you can join in. Now, without further ado, let's start today's webinar. Over to you, Ron.
Thank you for the introduction. I'm very honored to be here with you today, and thank you for being with us. I'm Ron, the CEO of Bionx. I'll give you an overview, an introduction of the innovative technologies that we developed here in Bionx. The microscope market, as you all know, is a very established one and being generated by a long history, companies that has a significant DNA of excellence in optical designs and ergonomics. We from Bionx come from a different approach and innovation that came from avionics that places the surgeon in the center of the operating room while controlling a significant future of the digital technologies and capabilities. And this I will give briefly in this presentation. As we all know, the trend today of technology in the operating room is shifting from analog to digital, basically by using cameras and 3D visualization screens, which gives a significant way and method of having connectivity to information that comes from inside and outside the operating room, giving capabilities of advanced guidance capabilities and softwares to improve surgery for different indications. And all of this is also preparation for the future, for data collection, data processing, having a smart surgery with artificial intelligence that eventually will give added value to surgeons. The paradigm shift that Bionx is bringing to the market is placing the surgeon in the center of the operating room. Like in aviation, having a cockpit, we provide independence for the surgeon, making her the center of the operating room with optimized data visualization and optimized control and efficiency. The way that you're going to control information and the systems during surgery is being made by head movements, head gestures, and this will give a significant advantage in the workflow in the operating room. Bionx is an Israeli company located in the beautiful city of Haifa in the north of Israel. We're a spin-off out of Elbit Systems, which is a very large commercial and defense company in Israel, a world leader in head-mounted displays. We develop ophthalmic visualization and tracking systems and plenty of software applications for surgery. Beyeonics One, which we expose today, is a high-end advanced visualization platform that provides augmented reality vision and allowing integration of an unlimited amount of data. We have a lot of heritage and maturity that was taken from aviation, from many years of experience, more than 50 in this large market of combat aircraft. And we took all that technology and advantage and transformed this into a high-end and sophisticated medical tool for operations for you. Beyeonics One is a full visualization system for both anterior and posterior segment surgery. This will place you in the center of the operating room and provide easily data access in real time during surgery. The system is composed of a very high resolution cameras and a display. We create a true and natural 3D immersive display with more than 8 times 4K resolution cameras. The system has a zero latency, less than 20 milliseconds, which creates a true and natural environment of real-time workflow. The user experience using the head gestures and the different human-machine interface that we created is very easy, super natural. The information access is very easy, bringing diagnostics and real-time data information into surgery. And all of this will give you a better decision-making during surgery. So what will the headset give you during surgery? A super sharp image. The image that we provide is equivalent to a 65-inch 3D 4K monitor at 1.5 meters in front of you. The display will be always around you, so you're the center of the operating room, no matter where you go. All the information is there. The control of the data and the system is intuitive and natural. So in this case, controlling B-scan of an OCT, intraoperative OCT device. In another case, it can be changing the focus or zoom of the system. And all of this is a see-through display, so it gives you the opportunity to be focused on the video you see in front of you, but also to have situation awareness, to see through the display in cases that you want, or even when you don't see a see-through and you see the display, you can see on the left, the right, and bottom all the things that happens in the OR, the staff, the nurse, your hands, and so on. So we're still focused on the image and on the operating room at the same time. So a lot of advantages that comes from using a head-wearable display in surgery, having you at the center of the operating room and maximizing the information. All the time you have a sticky screen, so you're not fixed to a microscope, you're not fixed to a monitor in the OR. The screen goes all the time with you, maximizing the visualization. The ergonomics is superior because you can sit in the comfortable zone for you all the time, and by using occasionally the head movements, the head gestures, this creates comfort on the spine and vertex, so you don't have any backaches or neck pains. The system itself comes with only one card and camera, so it's a small footprint in the OR, unlike monitors and additional equipment. And all this flow creates personalization for each one of the surgeons. It makes it easy to have teaching and training during surgery. And the synchronization between the staff is fantastic, all seeing the same things and being able to control and show and guide data to each other. This system comes also with an additional 3D screen on the wall, so the staff around you can be also synchronized to the surgery. This strong platform was developed for many years, and it was designed like your occasional standard iPhone or smartphone. It is based for growth and software growth capabilities. So on top of this platform, you will receive the advantage of a lot of clinical applications. Some of them will come in the form of connectivity to phaco and vitrectomy devices to show you the information that is critical to you during surgery on the headset. A data viewer that will enable you to see patient history, scans, and so on in real time during the surgery. Teaching tools that will enable you to guide the fellows easily during surgery, remote assistance, software and teaching that will enable you to view surgery from a distant location and give feedback during that process. Applications that will improve cataract surgery, bringing toric IOL or capsulorhexis LRI guidance to premium lens surgeries, effective lens positioning tools for accurate positioning of the lens, and advanced applications that will enable you to see and understand where your tool is inside of the chamber to prevent capsule tear and to give you additional valuable information during surgery. Additional tools for retina surgeries that will enable you to see better ILM peeling during surgery, tools for intraoperative OCT and preoperative OCT during surgery, and advanced tools for subretina injections for better visualization. All of these applications will give you the advantage that during the use of the device in the lifetime in your facility, in your center, the growth and the future will be already there. So you will be able to enjoy upgrades and additional softwares with time. So I thank you again for joining us today for this webinar. You're welcome to visit us in the conferences in the near term. We're going to present at the AO, Hawaiian High Retina Macular Society in Arvo. Early next year, we're going to have this system available for demos and for commercial use. You're all welcome to touch base with me. You have my email here, or any of the team members of Bionx. We'll be proud to answer your any questions and feedbacks. Enjoy the rest of the webinars.
Thank you for that great presentation, Ron. We will now be hearing from Anat Loewenstein, who will be sharing her personal experience of the Beyeonics One in posterior segment surgery.
Hello, I'm Anat Loewenstein, and it is my pleasure to share with you now my experience with Beyeonics One surgical visualization system. Retina surgery, albeit very, very advanced in the recent year, has still many unmet needs. Our department at the Ichilov Hospital, the Tel Aviv Medical Center, is the first beta site to operate with the Beyeonics One system. Multiple physicians have operated with Beyeonics One, performing both anterior as well as posterior and combined surgeries. To date, we did more than 100 surgeries in our center with the system. I would like to emphasize a few technical attributes to the system. The first attribute is enhanced visualization capabilities. As you can see in the images on this slide, on the top one you can see excellent imaging of the retina, and on the lower one you can see excellent imaging of the anterior part of the eye during cataract surgery. The system enables access to information upon demand, both to pre- and intra-operative information in real time. You can have on your head wearable device a customized display using side screen, picture-in-picture, any way you choose to have it. The control is happening with head gestures, which gives a lot of delicate maneuvering abilities and makes the surgeon completely independent. As you can see here, by movement of the head, you can flip between screens, you can look at the periphery, and you can get zoom and focus. These technical attributes are easily translated into significant clinical advantages. One of the challenges that we face in intraretinal surgery, in vitro surgery, is the ability to visualize very well the membranes that we are peeling. The Bionx system enables us to use digital color filters while performing ILM peeling. We know, all of us, that initiation of membrane peeling is still a delicate process which can lead to retinal damage easily if you pull on healthy retina. This, of course, happens more when there is limited visualization and when the membrane borders are not so clear, as happens very often with very delicate membranes. Using the Beyeonics One digital visualization system, the surgeon can view a high-resolution digital images of the retina. The use of digital color filters further enhances certain anatomical features such as the epiretinal membrane, ILM, and enables better distinction between the two structures. We try to evaluate the visualization quality of the ILM and epiretinal membrane as seen by a surgeon intraoperatively, and to evaluate how the use of digitally enhanced blue light filter and augmented reality modalities can provide a more informed image of the ILM ahead of the peeling. I will present you preliminary data from an observational prospective case series evaluating the Bionix One capability during epiretinal and ILM peeling surgery. Prior to the surgery, we did the general eye examination and OCT and Amsler grid. Surgery was performed using the Bionix system, and the questionnaire evaluating the surgeon's experience was performed immediately after, asking about depth perception, qualitative analysis of the portion of the membrane that appeared epiretinal as compared to non-filtered images, and the need to use dye to define the membrane borders, following dye-less imaging using just the filters. We encountered significantly better visualization of the macular area, as you can see in the images above, using the blue light filters, which enabled better membrane detection and peeling. Membrane detection was once more achieved when using dual blue staining of the membrane in cases it was needed. So we concluded that the use of blue light filter through the Bionix visualization system and its augmented reality visualization capabilities was beneficial in enabling the surgeon to define the ILM portion of the epiretinal membrane, reducing the need sometimes to inject retina toxic dyes that may be toxic to the retina. I'm showing you here a movie of Professor Adiel Barak from my department, who is performing a peeling of epiretinal membrane. Here you can see the use of a color filter, the way that it enables the peeling in a quite structured and safe manner. Another current challenge that we have is the visualization of the periphery. Usually, when we try to look at the periphery, we need to tilt the patient's head, and we might have difficulties in orientation once we move away from the posterior pole. Within the Bionix system, there is a panning opportunity where you can scroll within the visual field without moving the camera head, which enables spatial orientation. Magnification of any part of the retina without rotation of the patient's eye is possible. This maintains the high-resolution image also in the periphery. Namely, you can magnify any part of the retina without the rotation of the patient's eye relative to the wide lens by using the panic capability of the technology. Here you can see me using the panning characteristic for looking at the periphery in a very meticulous manner in an eye that has limited visualization, a pupil that is not regular, and you can see that using the panning you can get to very good visualization also of the periphery of the eye. Thank you.
Thank you very much for that, Anat. Our next speaker will be Robert Weinstock, who will be sharing his personal experience of the Beyeonics One in anterior segment surgery.
Hello, I'm Dr. Rob Weinstock from the Eye Institute of West Florida in Tampa Bay, Florida. And I'd like to talk to you today about my experience with the Bionix One surgical visualization system. Just as a little background, I am a cataract and refractive surgeon in the Tampa Bay area of Florida in the United States. And we are a multi-specialty practice with about 30 doctors of all specialties throughout all of eye care, including optometrists as well that are part of our group. And we have a large referring optometric network. I am primarily responsible for the cataract and refractive surgery in the practice. I perform somewhere in the range of 4,000 procedures per year. We also take a fellow every year that we train in cataract and refractive surgery. And we pride ourselves on, of course, outcomes, the latest technology for our patients, and the very best in customer service. We also have residents rotating through. We do a lot of teaching of ophthalmology as well as optometry residents. And we have been adopters of new technology over the past couple decades. I was one of the first surgeons in the world to prototype intraoperative aberrometry. I worked early on with microphaco and mixed small incision phaco, bimanual phaco, and cool phaco. I've also helped develop a lot of new technologies like the crystal lens, accommodating implant, and work early on a lot of the implants that are available, including the recently released in the US light adjustable lens. We also have a big interest in our practice in education, of course, and heads-up 3D technology. I helped a small company called True Vision going back a decade, helped them develop the very first 3D visualization system in ophthalmology, which subsequently has matured quite nicely and is now available commercially through Alcon as a product called Ingenuity. And we know Zeiss has also developed a product called the Artivo, which is a heads-up visual display system where the surgeon no longer needs to look through the oculars of the microscope, but can look at a giant 3D display in full high resolution in real time and operate in a much more comfortable position. And there's a lot of tremendous advantages to doing so throughout one's career. So what I'd like to talk with you today is kind of the latest generation of heads-up 3D visualization technology, and that's the Bionix One system. Earlier this year in 2020, early 2020, pre-COVID, I had the privilege and opportunity to use this novel and very new and unusual 3D display system on patients for cataract surgery. This was done through an IRB review since it was at the time not a 510K cleared device. And we placed it in one of our operating rooms and we performed over 50 surgeries over a 3-day period of time. In the other rooms, of course, I was using my other 3D display system. So I had a direct comparison of the image and the technology compared to other heads-up display systems that are currently available. What I noticed right away with this system, even in its early phase at the time, was the ability to implement preoperative information about the patient upon demand into my view, a very quick and easy and improved surgical flow in the operating room based on the design of the system, and a completely new immersive experience compared to what I'm used to, either through the microscope or through other visual display system, 3D systems. The learning curve was very quick. Now, of course, I do use 3D on a regular basis, and I'm used to operating heads up, so I did have a little bit of an advantage from that perspective. But as soon as I put the headset on, I was immediately able to begin operating comfortably. So there was no transition for me. Did a cataract case start to finish in just a few minutes, and from there on, every case in that room went completely uneventful, even challenging cases, and never had to revert back to the microscope or my more conventional Ingenuity system. I was able to operate through the Bionx system for the entire week that we had IRB approval to perform cases. I also had a lot of ideas using this technology about future applications and about the potential to augment the surgical view, bring information into the surgical view, and a lot of advantages digitally that we can do by having this kind of immersive experience and this VR experience, so to speak, with, you know, enclosed within this headset and having the surgical view and the other things that could be overlaid and used in that surgical view now that it's digital and not just optical through a microscope. So you'll notice here, you know, I just have a screen behind me that's showing the eye. You can see that I'm operating right here doing cataract surgery. And you can see I'm wearing this headset. And I'm kind of looking straight ahead right now. But I'm in a very comfortable position. I tend to get bad body posture sometimes. You can see my shoulders are a little slouched over. I guess I sit like that sometimes. I probably shouldn't. You can see that the microscope head and the optical system of the microscope is well away from me. It's pretty far away. I'm able to sit pretty far back if I want from the patient. But I'm free to move my body in any position I want because I'm not tethered to the microscope. There's no trouble seeing my hands below me because I can look easily either under or through the transparent screen to see what's going on. So this was right out of the gate, me operating on an eye and performing cataract surgery with the Beyeonics One system. This might have been my first case. I'm operating on a right eye here, and you can see my scrub tech is across from me. It's a pretty low profile system. The headset's very comfortable. It's got a little dial on the back that can, you can put on your head and make a comfortable fit. It's not very heavy at all, and the microscope doesn't get in the way. It's a very, very well designed system that just comes down right over the patient. So here's just a kind of another view straight on. You can see that my head's actually tilted a little bit to the right just because that happened to be comfortable at the moment. And I'm in the midst right here of being past the lens, or either it might be the IA tip. It looks like the IA tip. So my left hand is still in the eye with my irrigating chopper, and Jessica there is passing me an instrument, bringing it into me. My aspiration tip. So I don't really need to look over to her. I can look, she can put that in my hand. I can watch her put it in my hand as I look down a little bit to my hand and to the eye. But I don't need to take my head away from the oculars of the scope and look over at the scrub tech anymore, like I used to do when I operate through oculars, which is a huge distraction of taking your eyes off the surgical field, having to focus on something else, and then refocusing your attention into the eye. And in the delicate moves of cataract surgery or any ocular surgery today, we know that we want our focus and attention on the eye at all times possible. And that's one of these subtle features that systems like this allow you to do, is to stay immersed in what you're doing and keep your focus on every detail of what's happening intraocularly and not losing focus on that or visualization on that. So the software team and the engineering team of Bionx, we were brainstorming a lot with this, and we came up and implemented right on the spot, almost within a day, already applications that came to mind. Traditionally, I have a little face sheet that I have at the foot of the bed that says the patient's name, what eye we're doing, whether it's the first eye or second eye, what lens we're using, whether the femtosecond laser was used or not, where the astigmatism arcuates were placed, and any other notes about any complications, whether the patient's had previous retina surgery or has had RK or LASIK or has maybe had oil in the eye, whatever I need to give me a heads up, maybe on Flomax, whatever it is. It's nice to have information about what you're about to get into when you go to do cataract surgery, to give you a little bit of clues what you might be in store for and plan in advance. Well, we took a digital shot of that piece of paper, and we had it imported into the visualization system digitally. So when I was looking straight ahead, I could see the eye, and with a simple ask or a click of a foot pedal, I could bring in that piece of paper. Now, in the future, that'll all be pre-populated and digitally put in and be accessible and customizable. But right away, I was able to see that the ability to gather information about the patient's preoperative history or any type of information, maybe be a topography, an OCT that you could ask for on demand, maybe some other information that you might want to know. It could even be the name of the patient, just so you can talk to the patient or maybe connect with them, and maybe you have a background information about who referred them in, or maybe a family member that you've done surgery on, that you can create that bond with the patient and give a better experience. So this is a very different and unique way of thinking about eye surgery, to be able to gather information and use information, digital information, while you're operating. And also, this could be recorded. You could audio talk through the case or do an op report at the end right through this and send all the video and the audio to a server to store it, to record it, or to have it for future reference. And for teaching and for presentations, you could narrate the case right on the spot. Have it connected to your electronic health record, so it feeds right in, and information can go back and forth. So there's a tremendous amount of opportunities and things that we haven't even thought of yet. I'm sure many much smarter people than myself will think of all sorts of amazing things that can be integrated and automated with this technology. Okay, so here's just a quick video. It kind of just gives a look at what I'm talking about, where I can still see the eye, but in the top right of my screen is that information sheet that usually is on the foot of the bed, that if I wanted to see something about it, I'd have to take my head away and go look at it. But here I could press a foot pedal button and pop this little information up on the screen. In the future, obviously, it's going to be much cleaner, much more digitalized, but this is just an example of how preoperative information or critical information about the patient can be brought into you on the spot, on demand, during your surgery. And this was a very interesting feature for me, just to walk in a room, put on the headset, and instead of having to focus my attention somewhere else on a patient's chart or on a computer screen to see the name of the patient or what the surgical plan was, I just put the headset on and my information is right there in front of me, and I'm looking at the surgical field. Huge savings in focus, in time, in efficiency, in throughput, and just in enjoyment of surgery and the process without burdening you down with other tasks when you're trying to focus on getting a cataract out safely or do a surgery safely on an eye and on a patient. It's really hard to describe exactly what it's like when you're looking through this headset. Now, you can imagine that fighter pilots and jet pilots, military personnel, submarine, military applications, and all sorts of very high-tech individuals that are under high stress and high performance situations are wearing these helmets or headsets with visual displays to help them accomplish things and give them information to make quick decisions on. I don't think this is any different. I can't think of anything more higher stakes than someone's vision. And with what we do, we want to be able to do the very best job we can at that. So it's hard for me to describe what it looks like, but when you put this immersive headset on, it's a little different than maybe some of the other virtual reality things that you've worn or seen, that your kids have seen, where it completely covers your eyes and blacks you out. It's not like that. It's much more like what you would imagine of a fighter pilot, where it's more of a helmet with a gray kind of display that comes down, almost like a football player's helmet in a way, that have those protectors over their eyes. You can see through it well, and that's customizable where you can make it more transparent or more dark. But there is a happy medium setting where when the image is displayed, it takes up the whole screen. You can't see through it. All you see is the eye. There's no distraction of something behind it. But around it or below it, you can see your hands or part of the surgical field. Very natural. It's not like it takes any big adjustment. It's just, and by the way, when I first tried it, as I'm sure all of you are, a little skeptical, like this, there's no way this can be able to work. And I had low expectations. I did try it at one of the big show. I think it was at AO. I tried a simulation of it, and I was like, I went in very skeptical, and I was shocked at how good and friendly it was to use. And that's what kind of inspired me to say that I think I could operate on patients with this. I think this is going to work, which ultimately led to us doing the IRB and doing patients successfully. Great immersive experience, great ability to concentrate on the surgical field. The peripheral view actually allows you much better than you can through the oculars of a scope to have a spatial awareness of the other things that's going on, the machine, somebody coming in the room, not enough to distract you, but to know and feel good about your surroundings, as well as probably most importantly, the scrub tech passing you instruments, be able to see that without having to look away. I think we don't realize how restricted we are when we look through the oculars. We're really isolated in that position. We don't have any peripherals in play. We can't see our hands. We can't see the surgical field. There's a lot of in and out for doing things, in and out. And for complicated cataract surgery or retina surgery, there's a lot of in and out as you're getting instruments or sutures or putting ports in. You're always being able to watch the eye while you're doing that with this type of setup. It's really quite unbelievable. The other thing that I think blew me away was we're so used to this paradigm of using our foot pedal to focus into the eye, up higher on the cornea or down lower, and using our foot pedal to zoom in and out, which, by the way, is very clunky. Our feet are great for walking. They're not super fine motor skill instruments, our feet. And we tend not to focus and zoom as much as we would because our foots are not always in the right position and we blow it off a lot. We just kind of get by with the view we have. With this system, because of the ability of it to read your head position, you can program the headset to do whatever you want. So you're always looking at the eye. So as you're looking at the eye in there, if you move your head to the left, the eye moves with you. But that left head movement can cause the microscope to zoom in or out, and that could be out. If you want to program the microscope to do focus, you could go head up to focus up, head down to focus down. Your head and neck are extremely fine motor skill movements, and the ability to fine tune the proper zoom and focus is unlike anything I've experienced in any other type of view, because you can use these little micro movements of your head. So it obviates the need to use your foot pedal as this clunky mechanism. And at any time, little movements, but no matter what, you're still looking at exactly what you want. Now you're saying, well, what if you move your head by accident and you zoom and focus when you don't need to? It doesn't work that way because you put your foot and press a button down. That enables you to go into this zoom or focus mode with your head. And when you get where you want, you take your foot off and it's locked in at that. Now you can move your head freely, see the image wherever you're looking because it's right in front of you and you don't have to worry about changing a setting while you're moving your head. So very fluid, works really well. Probably one of the most unique features and most beneficial features of this system, which is pretty unbelievable and a complete game changer from what we're used to. So a lot of us, you know, we talk a lot about ergonomics, and there's a lot of data coming out now about the ergonomics of surgery, microsurgery. And there's a lot of people in our field that have suffered short-term disability, long-term disability, acute injuries with back or neck spasms or slip discs in their back, or chronic injuries that are over a period of decades where they have chronic neck and back issues that really limit their ability to operate. Some people have had to end their careers early because of this. Some people have needed surgery. I myself have had multiple injections in my lower spine for back issues, maybe not all related to surgery, but it doesn't help to sit in the operating room for 4 hours every afternoon in a posture locked in, possibly uncomfortable. We all know that every patient's head and bed and the way they bring the beds in are a little bit different. And no matter what, no matter how hard you try, it's never a perfectly comfortable position on every patient you operate on. It just can't be. It's just not that easy. This eliminates the need for that. This allows you the bed, the microscope can be at any height you want. It doesn't matter. You can operate with your hands up here if that's comfortable for you one day, or real low. Put that bed wherever you want it. You're always sitting comfortably in a natural position or whatever position you want, and you're always free to move your back and your neck and your head throughout the surgery because you're immersed in the surgical field with it right in front of you no matter what. You're not bent over, you're not tilted over, and you know, we don't have any data on this, but I think many of you would agree that when you are operating in an uncomfortable position as someone who has kyphosis and the patient's maybe in reverse Trendelenburg and you can't get your legs under the table or you have to tilt the scope and you're in an uncomfortable position when you're operating, you're struggling to get through that case because you're not comfortable and you're in pain as a surgeon. And I would go as far to say that you're more likely to make a mistake and you're more likely to have a surgical complication if you are distracted by pain, neck fatigue, uncomfortable posture, or struggling to do what you need to do. This really reduces all of those risks. And I'm hoping that technologies like this are going to allow people to extend their careers and not have to have chronic back and neck pain and really address some of that work-related injury that microsurgeons have to deal with. So here's a quick video just showing how I'm not even looking down. Here I'm looking down just to underneath the scope to get my hands into the eye, you know, but now I'm operating and I'm moving my head around. You think I might not be doing anything here. I'm actually phacoing right there with my head moving all around, just demonstrating how no matter where I look, I am in the eye and working comfortably. So if I feel a little something in my neck, or if somebody says something to me, I can actually turn my head towards them and still be looking right at the eye. And at that head's view, you can see it's a pretty low profile headset and I have great peripherals around it. So that's just a little demonstration how you're able to actually move your head around and see what you're doing, but yet still be operating comfortably. So that demonstrates something a little bit different than what we typically do with our heads up display systems like the Ingenuity and the Artivo, which are fixed screens that have to be placed across from you on the other side of the patient, just next to the microscope so you can look over at it. So yes, you don't have to bend your head over, but you still have to look over at this screen and get it in the right position. So there's a lot of play with getting the room set up right when you have a 3D monitor. And when you switch from left eye to right eye, sometimes it requires you to do a rearrangement in the room to bring the screen around to the other side, because you are now sitting on the other side of the patient when you go from left eye to right eye. So there is some little bit of some downtime and some throughput issues and efficiency issues with the current 3D platforms that you have to switch the room around. We've learned to do that very quickly, not a big deal. But this is another feature identified, is that this thing is just, since it's just a headset, there's no rearranging any equipment in the room when you switch from right eyes to left eyes. And there's not two pieces now. There's not, like normally with these 3D systems, you have a microscope and a camera, 3D camera on the microscope where the oculars usually sit. And then you have a separate big computer and box and screen that's a separate piece that is your viewing system. This is more of a other way around. The big part is the microscope, and the microscope you saw, and then it's just a small headset. There's no other big piece of equipment. I do a lot of teaching, so I am constantly watching my fellows operate, standing behind them usually in 3D. And I have a pair of 3D glasses on, and they're operating. I can guide their surgery and tell them what to do and what they're doing wrong and how to help them get through a case. If they're struggling, then I can come in and we can switch seats and they can watch me. This has the same capability that you could have 2, 3, or 4 headsets, and they don't even need to be standing behind you watching. They could be sitting somewhere else. They could be sitting in a conference room. They could be standing in the back of the OR out of the way. They could have the headsets on, and they could be watching, and there could be communication and assistance. And that is another amazing potential for this system, is for education and a lot of teaching opportunities. And once it connects to the electronic health record system, you could generate all sorts of stuff in back and forth between the two systems. So, it's a very quick learning curve. People ask me, was it hard to get used to? And the answer was no, right away. I was operating on eyes. You can see here, it's just one of the first eyes I was doing. It's just a low resolution 2D view, but on the left side of the screen, you can see me actually operating. On the right side is my body posture working, and you can see what's happening with my body and my head position. And compared to the other systems, we did a quick time study. It didn't take me any longer, and this is just on the first day of using it. It took me no longer to do a case with the Bionx system than I was using with the Ingenuity system in the other rooms. So, and that's like the very first day trying it. We was doing cataracts within 3 to 5 minutes, so it was no issues at all, no slowdown, and that was really just after the first day. So, really easy to integrate with a short learning curve on it. Some of the things that we're looking at to incorporate into it, some of the things that were looked at with other systems and have worked with, we're looking at potentially having OCT involved, so you could see the placement of the IOL and the capsule, or maybe any other details of the capsule bag via OCT that you can't see optically or through the digital camera image. Toric alignment softwares, overlays for that. Making a wireless headsets available. Right now it's still tethered to the microscope via wire, but wireless is coming, so you'll have even more mobility and freedom. And then remote teaching capabilities, where I perhaps could have a colleague of mine, my buddy Bill Wiley, who is up in Cleveland, who I spend a lot of time talking to, and we share ideas. He could have his headset on. I could text him and call him and say, "Pop your headset on, help me through this," and he could see exactly what I'm doing, and we could be communicating through our headsets, and he could give me advice, or I could watch him operate. Or if I want to do a remote course, we could give a bunch of people headsets, and they could be watching all over the country or the world. So telemedicine basically is what we're talking about, and telesurgery, and collaborative surgery is what we have here. We're no longer isolated alone when we're operating. We could have opinions, advice, and guidance from the experts around the world on particular things. This is something that's never been done before in surgery, this remote surgery. It's almost like a move towards robotic surgery. Ability to help somebody else when you're half the world away and help them achieve a goal and help a patient. This is amazing future applications and technology that are available here. We talk a lot about complications in cataract surgery, and we'd really like to do anything we can to develop technologies to reduce the incidence of posterior capsular tears or help surgeons do better surgery. There are all sorts of simulation type of tools that they have now, digital things with instruments where you can kind of get a computer guidance of how your skills are doing. And it was pretty cool to see some of these devices become available. Well, what if we combine those type of guidance devices about where you are inside the eye via OCT that help young surgeons or old surgeons alike know where they are and give them guidance clues, either visually or auditorily, about maybe being too deep or too close to the capsule. There's tremendous opportunities to potentially image and CAD the eye via OCT or other types of imaging software and then tie little probes and different sensors to the instruments to help us guide our surgery better and know where we are in space and warn us of potential problems. So I think the application is really limitless, especially with the era, the advent of the digital age we live in. This is probably where it's all going over the next several decades. Here's just an example of what it could be like to have an overlay of toric alignment for our toric IOLs. We've seen this with other technologies through the microscope. There's a few of them that come out. Aura was kind of the first one to start this, and Ingenuity and Alcon and a lot of the companies have similar things, Zeiss like this, but this will be available. And maybe even algorithms and IOL formulas to help guide it, depending on where your wounds are placed and things like that for surgically induced astigmatism. All sorts of metrics to help us. And again, as I mentioned, I can imagine a day where everybody has one of these headsets, maybe even at home, and people get called in the middle of the night from their fellows or residents, and they pop on their headset and see what the fellow's doing in surgery. Or maybe there is military application where there's a young eye surgeon out in the field somewhere or remotely who's kind of in trouble or needs help, and it's an urgent situation. And one of the world experts somewhere is on standby and gets a phone call, say, hey, pop on your headset, help me through this case. I mean, what a benefit to patients. And certainly, if I had something very unusual going on and I didn't have access to a world-class eye surgeon, how nice would it be to know that there was an expert that was engaged in my care? A lot of applications in this, obviously, with more complex urgent things like, unusual neurosurgery cases, things like that. But maybe it's a very new retina procedure that comes out, or an unusual case, and you could have collaboration of 4 or 5 retina experts at, like, say, submacular surgery or implanting some other type of sensor in the eye. Maybe with industry, you can have industry now checking in on how surgeons are doing and looking at how their technology is working in the eye without having to go all the way to the place and the facility somewhere and look at it on a 2D monitor or on a 2D low resolution video. They can watch it and see exactly what the surgeon's seeing completely remotely. And we know through COVID that remote communication is undeniably the future. So that kind of summarizes, my experience and my thoughts around this Bionix One, and it's a very new and exciting technology, and I think everybody's going to be really excited to see how this matures. And I'm sure many of you are going to want to get this in your own hands and your own operating rooms very soon. Thank you.
Thank you for sharing your thoughts with us, Robert. We're going to start our panel discussion. May I introduce our session moderator, Sharon Bakalash, Chief Medical Officer at Beyeonics. Okay, let's get going.
Thank you, Anat and Rob, for a very informative presentation. I'm Sharon Bakalash. I'm the newly appointed Chief Medical Officer of Bionix. Today, I would like to seize the opportunity of having 2 key opinion leaders around the virtual roundtable to have a multidisciplinary discussion around the needs of and wants of anterior and posterior segment surgeons when it comes to surgical visualization systems, and how digitally enhanced systems, particularly Beyeonics One, can answer those needs. So we have a few questions. I'll start with the first one. The question is for both of you. What challenges in anterior and posterior segment surgeries do you encounter today, and what do you anticipate will be able to be answered via a digitally enhanced visualization system? So the question is for both of you. Anat, Rob, who would like to start?
We decided that Rob will answer first on everything and I will top it up.
Perfect.
Well, it's a loaded question. There's always problems to solve, especially in anterior segment surgery. We have so many things happening in the field of refractive surgery, especially. We are using all sorts of refractive tools in the operating room now, digital tools for toric IOL alignment, IOL positioning, multifocal alignment, IOL power selection, information on targeting and biometry. And there's a big disconnect between all the preoperative testing and processes and what happens once you get into the microscope and start operating. So there's a big need for digitalization of the operating room environment and bringing in preoperative information, even intraoperative information, digitally into your view as you operate to help guide your decision making and help guide your maneuvers inside the eye. And hopefully that translates into better visual outcomes for the patients. And this is a big area of need and a big area of interest for ophthalmology and for all the companies in trying to improve informatics and digitalization and optimization of the surgical experience and help us with decision making intraoperatively. And I think this has already been explored some, but has a long way to go. Anat?
Yeah, I totally agree with you. I think that even though in surgery, in ophthalmic surgery, there have been great advancement in the recent decade, still there are things that where we could do better. I think that we still are challenged by sometimes visualization that is not perfect, especially when there are media opacities. I know it's your field to take care of them, Rob, but you're not always there, and sometimes there is more than a cataract. So I think that sometimes you have small pupils, you have opacification in the media that is not amenable to treatment right away. So there is still an issue of good visualization. I think there is still an issue with looking into the periphery of the retina in a very detailed manner. And there are issues to identify exactly where are the membranes, be it epiretinal membrane, ILM, fibrotic tissues on the retina, and to avoid damage to the retina. So all of these are areas where I think that digital visualization can assist us. And I'm not even getting yet to the pre and intraoperative imaging processes that we can have with the Bionx system that you started to talk about, Rob.
Anat, what is it that you, with your experience so far with Bionx, compared to your normal view through the oculars or through a bio or whatever type of visualization lenses you're using for seeing the retina with the conventional light source, what have you been able to do so far with digital imaging to enhance your view? What's been the big wow factor for you?
Yeah, it's an excellent question. So first of all, nowadays the visualization, the details that I can see with the Bionx system in the recent version, they are better than what I see with the microscope. There is also an ability to use various filters, and we are trying, it's still a work in process, to avoid the need to dye in order to identify the epiretinal membrane. And we have better visualization of the periphery using the panning function.
That's interesting. So is there any applications, that or filters that you're using on a regular basis with Bionx that perhaps I should try in the anterior segment to highlight maybe if I can't see the capsule and it's a bit of a...
Yeah, definitely. Yeah, definitely. I think with filters that with which we can see better the epiretinal membrane, you will see better the capsule.
That's a good point. I'll have to try that because, right now we have to put trypan blue in. It's an extra step and expense. Exactly. And if I remember from my cataract days, it also causes the capsule to be a little more fragile,
Yeah, so it's nice to go see it. Plus, sometimes you don't really need it, but you might get into trouble during the middle of a capsulotomy with a certain, maybe some cortical spoking, and you lose it for a minute, but you already have viscoelastic in the eye, so you don't want to have to take out the viscoelastic, put the air and the trypan in. I can filter on that would let me finish the capsule or enhance it right in that spot. That would be a tremendous advantage.
Yeah, it is. It definitely is. I think it is a great potential. And also potentially the digital visualization enables the enhancement of the image to see the epiretinal membrane better by just using digital optic manners that I'm not even aware of the exact technicalities of which, but theoretically I can see better, many more, better details.
Yes, and one thing I noticed right away when I used the Bionx system is that because I could control the zoom and focus with my head, fine maneuvers, I found myself wanting and having the desire to focus in to greater detail, maybe on lens epithelial cells on the posterior capsule, little tiny opacities on the capsule or on the underside of the anterior capsule to polish it. Really immersive and really being able to fine tune that visualization because of the head movements. Do you find the same way that you're a better surgeon because you have more fine control of focus and zoom?
Yeah, I think so. You know, this thing that we are operating barefoot because we want to feel the pedal very to the very little small movements. So we are operating barefoot, and actually with the movement of your head, you can get to this very meticulous fine tuning easier. So definitely, I think it has a big advantage also, the movement of the head as compared to the just pressing the pedal less or more.
Yeah. Now, you know, for our surgeries, which are typically much quicker, yes, we have some anterior segment reconstructions that take longer, but on a routine basis, the surgeries are fast, and maybe you don't see the...
You don't know how fast I do an epiretinal membrane.
Yeah, I know you're doing those in 5 minutes now, too. But I mean, do you...
No, I'm kidding. You're still faster.
You know, I mentioned in my talk a little bit about anecdotally, I feel like if you're in an uncomfortable position when you're operating, your focus cannot be on the eye if you're in pain physically or in an awkward position. And for you operating for longer surgeries, do you think that's real? Do you think that you're not as good a surgeon if you are in an uncomfortable or painful position while you're operating, and this might allow you to take the time needed to do it right or be able to focus better while you operate because you are so comfortable when you operate?
I think the answer to that is absolutely yes. I think it's a great question. You know, when I start to teach my residents to operate, regardless of the bionic system, I always teach them first how to sit. And I tell them you need to stretch to the microscope rather than to bend over to the microscope, because if you will not be comfortable, you will not be good surgeons. These little details, exactly like you alluded to, are really important in even for experienced surgeon, let alone for residents and new surgeons. I think it's really important to be comfortable and to make sure that you will not have personal issues where you are dealing with the eye. You just deal with the eye. So I think the ability of not being bent to the microscope or even stretching to the microscope, the ability to move your head wherever you want and you still see the same image, I think it's a great advantage for the surgery.
Absolutely. And, you know, you do teaching of residents. I take a fellow every year. And, you know, my fellows are using our current Ingenuity system to operate. They will be able to wear a headset and use this. I mean, it's shocking to me that some type of 3D technology, in my opinion, should be like in every training program because I
agree. Nowadays, I think a training program that is not implementing 3D visualization and heads up, I think it's not being cutting edge. I mean, they need to, in order to be cutting edge, you need to implement these technologies today. Agreed.
And it's going to impact patients' outcome down the road because these trainees are going to come out better trained with a steeper learning curve by being able to see exactly what the surgeon's doing perfectly without having to squeeze into an observer scope, which is uncomfortable. And I think that we're going to allow our trainees to do more because we feel more comfortable where they are. We can see what they're doing. We can see what's going on and guide them better. You know,
Exactly. And not only that, I think that you even have some tools, some teaching tools that you can implement because you can, for example, because it's a digital image, you can mark on the image exactly where you want them to do the sclerotomy or for you where to do the tunnel, the corneal entrance. So you have all these because it's digital, so there are many openings. And one other thing that I wanted to tell you that, you know, it's surprising to me because I'm letting my residents also use the Bionx system, and they actually get used to it really fast. It's the learning curve to switch from the microscope to the Bionx system for my residents was really, really fast. So I think it's also a good advantage of the technology.
I totally agree with you. My fellows are, when they come in and they see that we operate heads up, you know, most of the fellows that interview, they certainly do their homework and they see that. it kind of self-selects itself for a fellow that's looking for a very modern and innovative type of fellowship. They always have a little anxiety about going heads up, but within a day, they are like, I don't know what I was worried about. This is better than operating through the optics. So, I mean, we always say it's a little hard to teach an old dog new tricks. The proof is in the pudding that we have young surgeons just jumping right into this and having no trouble with it at all.
So I think you both covered a lot of territories here with regards to potential differentiators of Bionix One, both with the traditional microscope as well as with 3D systems. I'm interested to understand your thoughts. First of all, with regards to your own learning curve, how intuitive was that? How difficult was that to start operating with that, with the system? And I would also like to learn your thoughts about future functionalities of the Bionix One, and how do you think this one might bring clinical benefits to your surgery?
It's a good question. I might be a little biased and ahead of the curve on that learning curve question because I have been operating heads up with 3D systems for so long. So I am well versed in it. Anat will be a little bit more of a raw opinion on it because she's gone straight from conventional oculars right to 3D. But I can tell you that I had no trouble at all. I put the headset on and I did a cataract surgery right away. And what I noticed right away is that, of course, I had to learn how to use my head a little bit to do zoom and focus, which I loved immediately. And I just had a sense of freedom that I've not had before by able to, no matter where I look around the room or whatever, the surgical field's right in front of me. And I did find a more immersive experience because I'm so encompassed in the surgical field that I really enjoyed doing the surgery at a level. Not that I don't love doing eye surgery. It was a whole new level of experience for me. Which was amazing. So no issues on the learning curve. I think I did, like I said, 40 or 50 cases over 3 days. It was no problem at all, no complications. So no issues. And my staff really appreciated it because when we switched from left eyes to right eyes, they didn't need to take the big 3D screen and flip it around to the other side of the room. So our room turnover was a little bit more efficient using Bionx than it is with, say, a large format 3D visualization screen. So those are just a couple of things that we noticed right away.
Yeah, I have to tell you that I'm not a good example to talk about the learning curve because I started with the system at its very beginning, and every time I got used to it, which was pretty fast. The technology people changed something to make it even better, and then it took me some time to adjust to the new thing. But once it got to the present form, I think it's very easy to get used to it. And as I said, I can see it by the residents, and also when we have guests. For example, we invited as a guest Professor Rizzo from Italy. It's true that he is one, if not the best retina surgeon in the world, but he came at 4 a.m. in the morning because his flight was delayed, so we didn't have time to practice. He just practiced on a schematic eye for 10 minutes, then he went into the room and did 7 surgeries in one morning. So it's true, it's Rizzo, but there was absolutely no issue with the learning curve. Now regarding, I will maybe take the lead for the second question, and then Rob, you will supplement it for future applications. I think, so we are really looking forward into having both intraoperative OCT or registration of a preoperative OCT to make sure that we peel the membrane, that we know where to start the peeling, and to see real-time almost results. And I'm sure that also in anterior segment, if you're talking about, I don't know, implantation of toric IOLs, and you would like to see data, so it could be also helpful for anterior segment surgery, wouldn't it?
I agree. Torics, centering on the visual axis versus the pupil axis. I would love to see the depth of the cataract in a vertical type of imaging. So even if we could have simultaneous imaging that I could see my phaco needle going down on the side of the screen, and I would be able to tell how deep I am, maybe not for me, but for learning surgeons, or even type of sensors that can measure where you are related to the posterior capsule. I think there's a tremendous amount of guidance applications, both for refractive surgery and for complicated surgery, that can help the surgeon do a better job. So I mean, I think the main deal is going to be getting the companies like Bionx to prioritize which project to work on and what to do. And
I think the good thing about Bionx is that it's modular. I mean, you can add one thing and then add the other and so on. It's like a cellular phone almost. You can add multiple applications as you go. Yes.
And one thing that is for people that have tried 3D screens and have struggled with it, like a lot of people have demoed with it. Those 3D screens, it's imperative that the screen is you are completely perpendicular in front of it, and you can't be looking down on those 3D screens or up, or it reduces the 3D depth of field you have. So there are some people that, like, for example, if somebody is very tall and they come in the operating room and they're standing above me, behind me, their 3D view on the 3D screen may not be as good as mine, or if they're shorter, or if they're standing from the side. So this system, whoever is wearing the headset, if it's multiple people, they're seeing exactly what the surgeon's seeing. They don't have to worry about their angle and getting in position where they see the 3D screen properly. So it not only allows a little more freedom for the surgeon, potentially allows a little bit more freedom for collaboration. And again, if we're talking about like telemedicine opportunities, or if this world-renowned professor from Italy in the future, instead of him having to go into the operating room and maybe turning on a large format 3D screen to see what you're doing to collaborate, he could be at home and put on a headset, right? And he could see what you're doing, or you could see what he's doing while you're at home. And you
right,
can be
exactly.
back and forth on a microphone and assisting each other of interesting cases and collaborating.
Yeah, these are great insights. Yeah, these are great insights. You've talked a lot about the visualization attributes, about future applications. Where does information that is projected upon demand into the side screens come into play? What kind of information would you see as beneficial when projected into your visual field?
Well, I always have a clinical person in the operating room with me for making refractive decisions. And I think that's the biggest need, is decision-making in the operating room. We used to just come up with a surgical plan and then have the lens ready and then put it in the eye. There was no thinking during surgery. It's totally changed. We're looking at toric IOL, not only, any IOL. We're doing measurements on the table with intraoperative aberrometry and picking lenses. We're comparing our intraoperative measurements to our preoperative measurements that were done via biometry. There's multiple formulas sometimes that we want to see. There's different amounts of astigmatism that are measured on different machines. So I'm constantly asking, like, how much astigmatism and what axis did the IOL master show? What did the Galilei or the Pentacam show? What did the Barrett True K formula tell me for this patient? What did the SRK? Because I'm trying to make the best decision on the fly. It's very hard to assimilate all that auditorily. And potentially we have the opportunity for me to, via merging it with the electronic health record system, for me to visually see these things and bring them into my side screens up there and see intraoperative aberrometry on this side, what IOL power it recommends, Barrett True K, what it recommends, or the Galilei here and the Cassini here, what the axis was. It allows me also, it's like a double checks, because it's a checks and balances of not making any mistakes on what power and what the targeting is. You could even pull up the patient's history and your surgical plan, because, we're doing monovision. Are we getting the right eye? Is this supposed to be the near eye or the distance eye? Those are little details that are massive, massive importance in preventing mistakes and delivering good outcomes for patients. So all of this preoperative information, maybe also you're looking at, some other issue that the patient has with their retina, and it affects the lens choice that you're going to be using. So you want to know what all the testing is. Basically, it allows you access in the operating room to your entire EHR system on demand, potentially. think you're on mute again, Anat. Check your.
I totally agree with what you said, Rob. I think it has a lot of potential by way of these future applications. For me, the main thing now is OCT, but I can see many other things. I don't know, a tool guidance application, something that will alert me any minute I touch the retina when I'm trying not to touch it and just feel the membrane, and things like that. So there are multiple things that can come up, and we look forward to them.
Yes, absolutely. And thank you so much for all your insight. It sounds to me like we can summarize this discussion by saying this is more than just a visualization system, but rather provides a gamut of answers to current unmet needs in both anterior and posterior segments. If you could just summarize in, I don't know, one sentence, your thoughts about the future with Beyeonics One, in your center, what would it be?
Sure. I can see a time where there's many headsets, not only in our center being worn, but also remotely for teaching education. And I can see it to where this type of technology completely changes the way we do things and streamlines our surgical and decision-making process, and just allows us to continue to handle the high volume that's going to continue to come, but do it in a very efficient way that allows you to have better visualization, information at your fingertips, and just kind of merges the clinic into the OR. And allows you to, just to perform better all the way around, not just visually, but outcome-driven things as well, and collaboration.
Yeah, I think that Rob really summarized it nicely, and I will just maybe summarize it even more shorter. I think it's better visualization, comfortable ergonomics, and potential for multiple software applications that will enhance our surgical experience.
Well, thank you very, very much, both. This has been an eye-opener, and we look forward to working together in the future again. Thank you to the audience, and we are welcoming any offline questions from the audience via the platform and through our website. Thank you very much, and we look forward to working together.
Thank you. Thank you, Rob.
Thank you. Bye.
Thank you. Bye.
I'm afraid that's all we have time for today, but any remaining questions will be answered by email. Don't forget this webinar will soon be available on demand at theophthalmologist.com. You can also find more at Bionx.com. Look for Bionx Surgical at LinkedIn. Again, thank you to our speakers for their wonderful presentations, and thank you all for attending. Until next time, goodbye.